So I'm going to very briefly speak to you today about how we might assess symptoms in patients with IBS or other functional bowel disorders. So when you have a referral or have a patient in front of you with referred for either IBS or some kind of functional bowel disorder, it's really important, as with any patient, that we do a thorough medical history on these patients. So we might want to look at coexisting medical conditions that they've got, particularly those that might affect their dietary intake in some way. And also to check that other gut conditions have been excluded as possible cause of their symptoms. That might be IBD, so checking that they've had the appropriate tests for that. And we might want to look for, just check that they've had some sort of test of celiac disease. So that might be a celiac serology, or they might, and some patients have had biopsies taken for that. And it's really important that we check that these patients, when they've had their test of celiac disease, that they've been eating gluten. So it might be that they find that in the past, they might find that they've had symptoms following bread and pasta or other wheat-containing products or other grains, and therefore might have excluded them, and then not being aware that this would affect the ability to detect celiac disease, might have then had the test. So it's important to check that they were eating gluten at the time. So that will either be gluten in one meal every day for 6 weeks, or 2 slices of bread a day for 2 weeks before having either of those tests. If we've got blood tests, we might want to check those. And then it's also important to look at their current medications, particularly, again, any that might affect their gut symptoms in any way. And any previous medications, including those that they might have tried for these symptoms. So have they tried anything in the past, anything over the counter that they might have been recommended and hasn't perhaps worked, or has worked, or anything that they have previously tried. It's also important, again, as we would with any patient that we're seeing, to measure anthropometry, so their weight, height, BMI, and also any weight changes that might be relevant as well. And importantly, in these conditions, particularly, it's important to look at their social situation and their quality of life. And we know that these symptoms can affect quality of life significantly, and the symptoms can be affected and can affect social situations. So it's important to talk to them about their employment status. Are they employed? And what's their job like? What's their routine like? Do they go away a lot with work? Will that mean that dietary intervention, we might need to incorporate that into their dietary intervention, whether they're going to be able to implement the changes? Are they stressed in any way? Have they got any stresses in their life at the moment? So that comes on to the next stage with their home life. If there's any stress at home, that could be affecting their symptoms, or stress at work as well. It's important to think about their home life in general. So do they have a family that they cook for? What's their lifestyle like at home? Are they busy with young children? Is it going to be really difficult to make some of the dietary changes? It might be something we need to consider. And who does the shopping? Do they do it, or does their partner do it? And again, how difficult will that be to try and buy the right foods for your dietary intervention that you might recommend? So a lot of people will find that if their partner's doing the cooking and the shopping, it might be much more difficult for them to make these changes that we suggest. And like I say, cooking is obviously important to talk about that, and not just who does it, but what facilities have they got access to. So this is not different to other conditions that we might treat. So it's kind of similar sort of things that you might want to find out about every patient you see. And then also thinking about any social situations that might be different for different patients. So do they eat out a lot? Is there any sort of social stigma which might stop them making these dietary changes? Or is there anything else, like any religious issues which might, any restrictions in terms of their diet which we might need to consider? And also, do they do any exercise? Some people might find that doing exercise might help with certain symptoms that they have. So it's important to assess this, and if it could help their symptoms, perhaps they would incorporate some gentle exercise. So that's some sort of first line advice as well. So We need to have some sort of structured symptom assessment for patients with IBS and other functional bowel disorders, mainly because these are symptom-based disorders, and we don't have any biomarkers to tell us whether a patient specifically has IBS. We can't measure that in the blood or anything or any other way, and also won't tell us how severe their symptoms are. The only way we have is to ask them about them, and it's best that we do that in a structured way, because often patients' perceptions of what symptoms they have are not completely accurate. Sometimes they might report what symptoms they think they have, but actually what they perceive is slightly different to what we think they are. That might be relevant for things like people reporting that they have constipation or diarrhea, and actually when you ask in more detail, they might not fulfill those criteria, and so your management might be different according to what you actually find out that it is that they have. And also, if we want to measure the effectiveness of our interventions, we need to measure their symptoms in a structured way at the start and at the end, and that needs to be consistent at the start and at the end. So there are definite benefits of using some sort of structured assessment. And any assessment that we do use needs to be practical, so we need to be able to use it in clinical practice, therefore meaning it's not too time consuming in your consultation. You don't want to use something that's going to take half an hour to complete when you've only got half an hour with the patient. It needs to be simple and simple enough for a wide range of patients to use, with perhaps different levels of understanding of the measures, and also needs to accurately reflect the symptoms that the patients have. The main symptoms that we're interested in functional bowel disorders and IBS specifically is obviously pain and discomfort, or actually mainly pain, and because that's the hallmark symptom of IBS. But there are lots of accompanying symptoms which we need to inquire about. So lots of patients will report bloating, flatulence, and also we need to assess their stool output, and particularly in terms of subtyping IBS and whether they're IBS diarrhea predominant, constipation predominant, mixed or unsubtyped. So asking about these symptoms is really important, and also whether they have any urgency symptoms and incontinence, which is possibly something that people might not offer up without being asked. And do they have alternating bowel habits? It might be really difficult for them to describe their bowel habits because they're different every day. So it's worth asking about the frequency with which they have one particular bowel habit and another, to see what exactly is going on. And then there's also other upper GI symptoms which aren't included in the criteria for diagnosing IBS, but a lot of patients will refer to these symptoms, like nausea, abdominal gurgling, heartburn, acid regurgitation, and low energy levels are also really common. So we don't just want to look at what symptoms the patients have, but also ask about the onset and duration of the symptoms. So when did the symptoms start? Was it with a particular stressful life event? Was there a change in their diet which triggered the symptoms? Was it with a bout of gastroenteritis, which we know it's common for patients to develop IBS symptoms in the long term following gastroenteritis, or was it following some sort of gut surgery? And how long have they had those symptoms? And it's also really important that we assess the frequency with which they occur, and also the severity. So some patients might have pain every day, but it's really mild, whereas other people might have pain once a week, but it's so severe that it stops them working or stops them doing what they normally would do. So it can be very different from one patient to the next, although they both have pain. And also looking at bowel motions that they have per day, and like I said, whether that varies. It also might vary within one bowel motion. Perhaps it's really difficult for them to describe, and I'll come on to assessing stool form later, but it might be difficult for patients to describe because it varies so much even within one motion. And it's important to think about any patterns that the symptoms have. So are the symptoms different when they're on holiday, and is that because they're more relaxed, or are they worse because they change their diet when they go on holiday? And are weekends different to weekdays? And again, that might have the same thing. So it might be that they're more relaxed at the weekends and the symptoms aren't as bad, they're not as stressed because they're not working. Or their diet might change from their usual routine, so they might end up having more symptoms at the weekend. So it's worth asking about those patterns as well. So there are various methods that we can use to assess patient symptoms at the start and at the end of our interventions. And these can be used in research and in clinical practice. So first of all, you've got the adequate relief question, or the global symptom question. And this is usually, do you currently have adequate relief of your gut symptoms, yes or no? So it's a dichotomous outcome that can only say yes or no. And this was previously regarded as the standard for measuring symptoms in clinical trials of functional bowel disorders or of IBS, or in IBS trials. But recently it's been sort of criticised to some extent with regards to possibly being confounded by baseline symptom severity, meaning that patients with the milder symptoms at baseline might be more likely to have adequate relief at follow-up compared to people with more severe symptoms. And also it's been suggested to possibly not detect minimal clinically important differences. And it doesn't provide any information on the degree of improvement of individual symptoms. So if it's asked in isolation, you don't know if the intervention you're giving is particularly improving pain or bloating. And particularly in a research setting, it might be important that you go into a bit more detail. But the benefits of it is that it's very simple to give to patients, although I would argue that some people do find it very difficult to answer because not a lot of people, some people don't understand what it means by adequate relief and what we're comparing it to. It's difficult to say yes or no. A lot of people want to kind of go in the middle. But I would argue that it possibly does represent the most clinically important outcome for the patient. So we're really trying to achieve a point where the patient feels that their symptoms are well controlled, and this is essentially what the question asks. And you can add a period of time to it, so you can modify it slightly. It might be over the past 7 days, do you feel you've had adequate relief of your gut symptoms? And secondly, we have visual analog scales, which are usually a 10 centimetre line, where patients have at one end, they can be used in different contexts, so they'll have, perhaps we're asking about symptom severity. At one end you might have your symptoms are terrible, so how severe is your pain, for example. You might have very severe at one end and no pain at all at the other end. And patients are asked to put a line somewhere or across somewhere on that 10 centimetre scale to indicate the current severity of their symptoms, and that might be over a particular time, so in the last week or the last 10 days. There are some limitations with these scales, and one of the main ones is that some people are more likely to have central or polar tendencies, so they're more likely to put to mark in the middle or at the ends, regardless of what their symptoms are like. And this makes it difficult to compare different people in terms of their responses. But what it can be used for is measuring a patient's response to a treatment over time. So in the same patient, looking at their differences in the scale. Then we've got Likert scales, where there are a defined number of responses to a particular question. These are ordinal scales, usually 4 to 7 responses. They have the same limitations as visual analog scales, that some people have central or polar tendencies. And so some people have suggested that it might be better to give people an even number of responses so that they can't go for the middle option. But that's sort of up for debate, I suppose. And also what it means that because they're sort of categorical, you can't calculate a mean value for a group. So again, in research that might be worth considering. So if you're looking at assessing a group of patients over time, then calculating a mean is difficult. Then we've got modified Likert scales, for example, the gastrointestinal symptom rating scale. So what this is a list of symptoms, and patients are asked to rate the severity of those symptoms as either absent, mild, moderate or severe. And again, this might be over a particular period of time, a defined period of time. And the responses are also qualified with both frequency of the symptoms and severity. So, for example, moderate would be frequent symptoms that affect some social activities. So that's another way of measuring a range of symptoms. And then you've got integrative symptom questionnaires, such as the IBS severity scoring system. And this particular scoring system is made up of a range of visual analogue scales and also a question about frequency of abdominal pain. And this covers the past 10 days, and you can get a score out of 500. So it's made up of 4 visual analogue scales and 1 question about pain frequency. So it's quite focused on pain, so most information about that. And again, it has the limitations of the visual analogue scale, being that it's made up mostly of visual analogue scales. And it also lacks an assessment of other symptoms which might accompany IBS, like flatulence, urgency, and the score isn't, the frequency and consistency of bowel motions doesn't contribute to their score, so it kind of lacks that assessment. But in combination with other measures might be a useful tool. There's also the Birmingham IBS symptom questionnaire, which isn't used as frequently, but is made up of a series of questions where patients are asked to rate the frequency with which they've had this particular issue. It's not, sort of focused more on bowel habits, and there aren't really any questions about flatulence or bloating, which are also really common in IBS. And also it lacks an assessment of symptom severity, so it's really just frequency. So it's limited in that respect, that it doesn't ask anything about how bad the symptoms are at the moment. It's also asking patients to recall the last 4 weeks, and I think probably be quite difficult for people to remember, unless they're very aware of their symptoms. To remember like 3 weeks ago would be difficult. So in terms of measuring stools, it's worth assessing the frequency of bowel motions, and there are different ways to do this. So you might ask how frequently they open their bowels per day or per week. In terms of consistency, we generally use the Bristol Stool Form Scale. It's the most commonly used scale for assessing stool form. And it's recommended by the Rome 4 criteria for subtyping IBS into diarrhea, constipation, mixed or unsubtyped. It's fairly simple to use and has been modified to be pictorial, and so this can really help patients to classify their current stool form. And it does have substantial validity, but a recent study has shown that there might be difficulty in correctly classifying stool form around the clinical decision-making points. So that's between normal and abnormal stool. So generally we would say type 3, 4 or 5 would be normal stool form, type 1 and 2 hard stool, and type 6 and 7 loose stool. And so between type 5 and 6 and type 2 and 3, there can be difficulty in correctly classifying stool form. So there are limitations of this measure, but fairly simple for patients to use. But again, like I said earlier, a lot of patients will find that they have a mixture of them, and they may want to tick more than one type, and that might be within one bowel motion. This is the symptom assessment form currently used at Guy's and St Thomas's, and this includes a range of different measures for assessing patient symptoms. And this isn't what you necessarily should be using, but it's just a suggestion of how symptoms can be measured. So first of all, you've got the adequate relief question. Do you currently, in the last 7 days, do you feel that you've had adequate relief of your gut symptoms? Yes or no? And then that's kind of explored a bit further in terms of symptom severity using the gastrointestinal symptom rating scale, and then stool frequency and form rated using the Bristol Stool Form Scale. So that's sort of in one quite short form that is a way that the symptoms and stool output can be measured at once. We know that quality of life can be significantly affected by IBS symptoms, and it's worth possibly measuring this in our patients in terms of the impact the symptoms are having on quality of life. There are generic tools that can be, generic quality of life tools that can be used in IBS and other functional bowel disorders, such as the short form 36. And this can be used to compare quality of life of IBS patients to other conditions, but there isn't much weighting to the effect of gut symptoms on quality of life, so it's limited in that sense. Whereas we do have IBS specific tools for measuring quality of life, such as the IBS QOL questionnaire. So this is a range of questions relating specifically to the gut symptoms and the effect that those will have on a quality of life. It's worth, if you want to use this, just checking the conditions and whether you need to pay to use it at all. Finally, I just wanted to mention very briefly dietary assessment, although this talk really focused on symptom assessment. But in these patients, before you sort of decide what your dietary intervention will be, it's worth assessing any foods that they've previously excluded, or any dietary strategies that they've previously tried, anything that they've perhaps found hasn't worked. And it's also worth assessing whether they carried those out appropriately or correctly, and it might be worth trying it again with your guidance. Do they have any perceived triggers of their symptoms, and why do they think those foods trigger their symptoms? And is it worth us challenging those triggers that they think they have? So people might, they might say, "Oh, peppers make my symptoms worse," or "tomatoes do," but when they're eating a mixed diet, it might be very difficult to identify whether that food is actually a trigger or not. So it might be worth suggesting that they do it in a more sort of structured way to try and find out if that's a trigger. Is their diet nutritionally adequate? Are they eating regularly? Are they taking time over their meals? Are they rushing their meals on eating on the go? Are they eating one big meal in the evening and not eating much at all during the day? And could that be contributing to their symptoms in the evening? And it's worth assessing fibre, fat, caffeine and alcohol. Although there's limited evidence for these strategies in IBS, in some patients they might find that reducing or increasing certain types of fibre might improve their symptoms, or restricting caffeine might be enough to reduce their symptoms. They might find that really strong coffee does make their symptoms worse, and if it's as simple as that, then they don't need to go on to any more restrictive dietary strategies. That's preferable. And if we're possibly thinking about advising on the low FODMAP diet, it's obviously important to assess their FODMAP intake. And it might be obvious that they're having a lot of fermentable carbohydrates, and that could be contributing to their symptoms, depending on the symptom profile that they've got. So it's worth just doing an assessment of their overall FODMAP intake as well. So in conclusion, we really need to obtain a complete picture of a patient's symptoms, thinking about the type of symptoms they've got, but also the frequency and severity of the symptoms, and also how that might be affecting quality of life, and whether their social situation will affect what interventions they can carry out. And it's also important to objectively assess symptoms, because it's very difficult to look at their response without a structured symptom assessment tool. And all the tools that we have, they all have strengths, but they also have limitations. So it's worth considering those when you're choosing the tool that you might use in your practice.